Good evening, everybody. So we shall start with the lecture today on autoimmune liver disease in children. Giving some outline and layout to the talk today, I'll be discussing a little bit about the background, pathophysiology, types and terminology of autoimmune liver disease, clinical features, diagnostics, finally management and follow-up. In the end of the speech, I'll be giving 4 case scenarios just to imply the practical aspect of what we talk today. So, in background, autoimmune liver disease was first described by Wolstenholme in 1950s. Actually, he described this disease in association with SLE, systemic lupus erythematosus, and he linked the disease name to lupus hepatitis. Since then, it went through an evolution, and now we have autoimmune liver disease with several types, which we are talking today. So, given key features as the background, this is an inflammatory disorder of the liver characterized by raised transaminases. As you all know, you have to have an abnormal liver profile, raised immunoglobulins, positive autoantibodies, interface hepatitis on liver biopsy, with or without bile duct injury on cholangiogram. This is where we would think about autoimmune liver disease and we would suspect autoimmune liver disease. The disease is more aggressive in children and adolescents compared to adults. So the treatment is also quite aggressive compared to adults. The incidence of autoimmune liver disease is actually on rise. Nowadays, we do not see much infectious hepatitis, viral hepatitis. Instead of that, we see more autoimmunity and acquired liver diseases, like non-alcoholic fatty liver disease. So with this transition of the disorders, the incidence is on rise. More importantly, I would like to highlight that this is a treatable disease, treatable liver disease. If we take the types of liver disease we see in children, only a handful of diseases are treatable with specific medications. Most of the disorders are inherited and ultimately would require liver transplantation. What we would do mostly is giving supportive care and offer monitoring. However, the diseases like autoimmune liver disease and Wilson disease are 2 main diseases where specific treatment or medications are available. So it's very important to consider these possibilities and start treatment given the background that they are treatable. Little bit about pathophysiology before we going into the main clinical presentations and diagnostics. The etiology is multifactorial in pathophysiology of autoimmune liver disease, where you can't really say this particular genetic mutation is causing the disease. Genetic factors, epigenetic factors, and maybe environmental modifications, everything might play a role. Mostly acquired, and sometimes the triggering factor is an infection, vaccination, or maybe a drug which is given for some other purpose. The disease involves a chronic inflammatory process, and the inflammation is mainly governed by T-cell mediated immune response, which happens against liver antigens. Essentially, the disease is linked to autoimmunity. That is why we see other autoimmune diseases in children who has got autoimmune liver disease. And similarly, when somebody has got another autoimmune disease, we would think about autoimmune liver disease as well. Let's now move to look at the types of autoimmune liver disease and the terminology, because it will be important for us to understand the types we talk about before moving to the next slides. It is quite simple. We have 3 main types of autoimmune liver diseases we talk about in children. The 3 main types are autoimmune hepatitis, where only the parenchyma is affected, or the liver cells are affected up to a greater degree. Autoimmune sclerosing cholangitis, where the bile ducts are affected due to the inflammation. It could be intrahepatic bile ducts or extrahepatic bile ducts. The third category is de novo autoimmune hepatitis following liver transplantation. This is a disease which happens after liver transplant or a transplanted graft where the primary disease was not autoimmune liver disease. For example, the child was transplanted for Wilson disease, and after the transplant, on monitoring you see raised liver enzymes and then has got the picture of autoimmune liver disease. So that is de novo autoimmune hepatitis which occurs following liver transplantation. The biochemistry, diagnosis as well as the treatment is completely same as autoimmune hepatitis which occurs in otherwise well children. If you take autoimmune hepatitis, there are two main types which we have to be familiar with. Autoimmune hepatitis type 1 and autoimmune hepatitis type 2. The classification is again based on the antibody positivity, to which we would come later. But for the people who are curious, I would just mention the autoimmune hepatitis type 1 is characterized by the positivity of ANA as well as anti-smooth muscle antibodies. In contrast to that, the type 2 is characterized by anti-LKM antibody positivity. And there are other types of antibodies as well, we would come to that. And we often talk about this overlap syndrome. It's not that simple when it comes to clinical practice, and it is not very clear cut. Sometimes you see a bit of both. That is where we discuss overlap syndrome, where you have parenchymal involvement as well as biliary tree involvement. There are other terms which appear in articles, and when you search in the literature, I just wanted to mention those terms as well, just to avoid confusion. The primary sclerosing cholangitis is interchangeably used for autoimmune sclerosing cholangitis. In certain literature, they do talk about primary sclerosing cholangitis. In some literature, they talk about autoimmune sclerosing cholangitis. However, the terminology is slightly different in children compared to adults as well as the treatment. In adults, the primary sclerosing cholangitis, they do not treat with immunosuppression. They would just manage the biliary strictures and go for transplant. However, that is not what is described in children. Autoimmune sclerosing cholangitis, we do talk about treating them with immunosuppression. Possibly the pathophysiology is different. So it's better to call autoimmune sclerosing cholangitis rather than primary sclerosing cholangitis. One factor which would support that is primary sclerosing cholangitis means you don't have any specific reason for that, like autoimmunity, it's just primary where you can't really find a reason. But here we do link it with autoimmunity. And there are other types of sclerosing cholangitis in children. So it's kind of a misnomer, better to stick to these three main types to avoid confusion. Let's look at some distinct features of autoimmune sclerosing cholangitis compared to autoimmune hepatitis. The bile duct involvement is classic in the disease compared to autoimmune hepatitis. Due to that, itching is a cardinal clinical feature. The disease is increasingly recognized with inflammatory bowel disease, especially ulcerative colitis, but can occur in with other types as well. Importantly, the disease activity of the liver or the bile duct is correlated with the bowel disease activity. So controlling the bowel disease activity would definitely be beneficial to control the liver and bile duct injury. The disease is quite equally distributed among males and females in contrast to autoimmune hepatitis where more females are affected. If you take the responsiveness of the disease to treatment, sclerosing cholangitis is less responsive to immunosuppression compared to pure autoimmune hepatitis. And they will have a higher chance of being progress to end-stage liver disease early. Complicating the matters further, after transplant, the risk of recurrence is also higher in sclerosing cholangitis compared to autoimmune hepatitis. Having heard of that background, we shall move to look at the clinical presentations. How would the child with autoimmune liver disease present. The presentations may be divided into broad categories. The child might come with a clinical picture of acute hepatitis, or it may be acute liver failure. Sometimes it is acute and chronic liver failure, or compensated chronic liver disease with or without portal hypertension, which may be incidentally found, or just transaminitis when the child was investigated for viral illness. Those are the main modalities of clinical presentations we would see in clinical practice. IBD-associated liver disease again is very important. You may diagnose a child with inflammatory bowel disease and then screen for the liver disease and diagnose the liver disease. If a child has got one autoimmune disorder like thyroiditis, type 1 diabetes mellitus, you might keep the child under surveillance for other autoimmune disorders. That may be the scenario where the liver injury might come into the clinical picture. So these are the broad categories we would see in our clinical practice in relation to autoimmune liver disease. What would be the presenting features in view of history and examination? They are often not very specific and variable. It depends on the clinical presentation, as I have mentioned earlier. History-wise, the child may have constitutional symptoms, and importantly, the disease is preceded by an infection. This would give us diagnostic dilemma actually. The child might have a viral illness. With that, we would see the transaminitis. And we may think this transaminitis is due to the viral illness or just an infectious hepatitis. But that may be the trigger. Or maybe there is a history of preceding viral illness, where there is a 2 to 3 weeks gap. Both could occur. Environmental triggers, drugs, again are possible in the etiology and the history. You might see a child who would complain of yellow eyes, abdominal pain, and being just unwell, dark urine, itching may be present, and family history of autoimmunity may be there if you inquire into the history. Examination-wise, again, there are no specific features, unfortunately, to say this is autoimmune liver disease. However, they would have the general clinical features or the signs of liver disease like jaundice, stigmata of chronic liver disease, abdominal distension due to organomegaly, ascites. Sometimes they may have pallor, maybe due to the feature of chronic liver disease, or they might have autoimmune hemolytic anemia. And the clinical features or the signs of inflammatory bowel disease may also present. If a child presents with that kind of a non-specific clinical presentation, we would always have to consider competing differential diagnosis. Because autoimmune liver disease is mostly a diagnosis of exclusion because we do not have a single test to say or single gene mutation to say this is autoimmune liver disease. So it's quite challenging. So these are the competing differential diagnoses. Infectious hepatitis like hepatitis A, B, or C, and non-ABC infectious hepatitis. There are various types of viruses which could cause the similar picture. We might not have the ability to diagnose those viruses in our setup. Wilson disease, often a diagnostic dilemma. It would compete with the diagnosis of autoimmune hepatitis mostly. Non-alcoholic steatohepatitis, again common in current context. Drug-induced liver injury. The history of drug ingestion may not be evident at first presentation. The family might not disclose. Rarely, the possibility of glycogen storage disease and other rare metabolic diseases also need to be considered. These are the main competing differential diagnoses in our setup. However, in the West, alpha-1 antitrypsin deficiency is also considered as a main differential diagnosis, which we do not see in our setup. If you have those clinical features, having kept those differential diagnoses in mind, how would you make a diagnosis of autoimmune liver disease? The challenge is there is no single objective test. So you have to go by the subjective parameters which could vary or which could be confounded by multiple factors. Let's look at the key characteristics. The supportive history and examination. maybe a background history of inflammatory bowel disease or the background family history of autoimmunity. All these things might have a positive influence on our diagnosis. And these are the key features you might consider in the diagnosis. You need to have abnormal liver profile. We would come to that. The main liver blood test would be abnormal. You will have transaminitis and other enzyme abnormalities. 100% you need to have that. Raised immunoglobulin. Unfortunately not 100%, it is 90%. You can have autoimmune hepatitis with normal immunoglobulin. And on the other hand, the other disorders can cause increased immunoglobulin as well, just like a chronic disorder, chronic liver disease, due to other etiologies, can cause polygamma globulininemia. So it might cause raised IgG picture. Positive autoantibodies, only up to 75% of the time. And we all know ANE could be positive up to 7% of the normal population. So we do not know whether that is really pathologically significant. That is where our antibody titers become important. Suggestive liver histology. Liver histology is crucial for the diagnosis. In very experienced hands, 100% time it should be there. And last but not least, it's very important to exclude other differential diagnoses. So we should consider this in the absence of other known etiology. There are a few misleading things. As I mentioned earlier, raised immunoglobulin could be present in other chronic liver diseases. So just because the immunoglobulins are high, we can't really say this is autoimmune liver disease. And some people do try to correlate the relationship of AST, ALT, AST more than ALT or ALT more than AST. There is no such thing. You can have both patterns. So there is no real pattern of AST, ALT in relation to one or the other. And only ANA positivity again can be misleading because it can be present in normal population. So let's look at one by one. How would the liver profile be helpful or suggestive? Transaminases are usually significantly raised in autoimmune hepatitis. You will see transaminases in thousands if it is autoimmune hepatitis. The figures are quite lesser in autoimmune sclerosing cholangitis, where it would not be in thousands, it may be in hundreds or maybe in double figures. Gamma GT raised in both autoimmune hepatitis and autoimmune sclerosing cholangitis. It is raised up to a great extent in autoimmune sclerosing cholangitis. I'm not bringing the de novo autoimmune hepatitis into the picture because you can just assume that it's equal to autoimmune hepatitis because it's more or less similar. Only difference is you have a transplanted liver. Alkaline phosphatase raised in both conditions but very high in autoimmune sclerosing cholangitis. However, it could be confounded by vitamin D deficiency, so we have to be careful. Albumin is not specific for the diagnosis. It would indicate impaired synthetic function and chronicity of the disease. Clotting would indicate either vitamin K deficiency or again impaired synthetic functions, not specific. Bilirubin is raised in all types up to a variable degree or maybe normal, relatively higher in autoimmune sclerosing cholangitis. So if you look at overall, you have some idea the transaminases are quite higher in thousands in autoimmune hepatitis, but otherwise it's not really specific. Let's look at immunoglobulins. What's the cutoff? Usually it is more than 1600 if it is suggestive of autoimmune hepatitis or autoimmune liver disease. Present only up to 90% and may be negative initially. It is very important if you have a clinical suspicion of autoimmune liver disease. Though the immunoglobulins are normal, you may repeat it after an interval, maybe after weeks or months, where it might become higher. So do not give up on your diagnosis. If the child has got persistent transaminitis, you may repeat immunoglobulins after giving some time. So first finding being normal, you can't exclude autoimmune hepatitis, autoimmune liver disease. As I discussed earlier, it might be raised and give a false positivity in other types of chronic liver disease as well, because polygamma globulinemia may be there in chronic liver disease. What about autoantibodies? It is always beneficial to have autoantibodies in titers rather than just positivity negativity. However, it would be practically and financially difficult in our setup, but if it is possible in ideal setup, it's good to have. And the rise in titers are quite important in the diagnosis, and in the follow-up, decrease in titers are important. Let's look at main three types of autoimmune liver disease. I have not brought de novo autoimmune hepatitis here because you can just assume it could be one of these. So autoimmune hepatitis type 1, you get ANA positivity and anti-smooth muscle antibodies positivity. Others could be variable. However, anti-liver kidney microsomal antibody and anti-liver cytosol antibodies would not be positive. If they are positive, you have to move to autoimmune hepatitis type 2. In sclerosing cholangitis, the characteristic thing is PNK positivity. However, it's not specific. So this is the antibody profile we may consider doing if we have a suspicion about autoimmune liver disease. And it's very easy if you have anti-liver kidney microsomal antibody or anti-liver cytosol type 1, which would put you under autoimmune hepatitis type 2 category. In the absence of that, mostly it's autoimmune hepatitis type 1. What's the place for liver biopsy in terms of the diagnosis? It is the gold standard actually, though it's not really 100% specific. In the context of having supportive biochemistry and in good hands, experienced hands, it's very, very helpful. An autoimmune liver disease is a diagnosis which you can't make without a liver biopsy. Nowadays, with the availability of genetics, you can make a diagnosis of Wilson disease in the absence of liver biopsy. You can make a diagnosis of glycogen storage disease in the absence of liver biopsy. However, you can't make a diagnosis of autoimmune liver disease in the absence of liver biopsy. You really need to have it. For you to interpret it as a good biopsy, you need to have at least 12 portal tracts. So it should be in good size. What are the key features the histopathologist would look at? Presence of portal inflammation, consisting mainly lymphocytes, plasma cells, expansion of portal tracts, and liver lobule. The liver lobule will be expanded as well. Interface hepatitis, the key feature. Destruction of the hepatocytes at the periphery of the lobule with erosion of the limiting plate. Rosettin formation and bridging fibrosis, and sometimes if it is acute presentation, you might see hepatocyte necrosis and collapse. If you have overlap syndrome or sclerosing cholangitis, you will have bile duct inflammation, and in severe disease, you might see bile duct loss. In children, usually we encourage doing liver biopsy under anesthesia with the help of an interventional radiologist in the current setup. In the West, they do always couple this with upper GI endoscopy. The reason for that is in the West, they have a higher prevalence of celiac disease. So if there is a child who is suspected to have autoimmune liver disease in UK, they would just plan upper GI endoscopy and liver biopsy together under same anesthesia because of higher prevalence of celiac disease. In our setup, we don't really have to do that, but if you have features of chronic liver disease, you may couple it with an endoscopy because you anyway have to do a surveillance endoscopy to see varices. And if you are doing it under anesthesia, so it's always beneficial to look through the gut as well in view of upper GI. So these pictures would give you more insight how the liver would be in autoimmune hepatitis and sclerosing cholangitis. So on your left-hand side, you would see a normal portal tract, which consists of a vein, a branch of portal vein, branch of hepatic artery, and branch of the bile duct, which is bile duct tube. And in the second picture in the middle, you can see autoimmune hepatitis with mononuclear infiltrates, where you can see a lot of bluishness in the area, and you can see a bile duct here and around which also there is inflammation. Possibly there is a component of overlap as well. The third picture illustrates a classical appearance of sclerosing cholangitis. Here you can see the onion peel appearance around the bile ducts. That is the classical feature the histopathologist would look into, say this is sclerosing cholangitis. So far we have discussed about the liver biochemistry, immunoglobulins, autoantibodies, as well as the liver biopsy. Moving into imaging, we would invariably perform ultrasonography in a child who has got abnormal liver enzymes. So how can that be helpful? It is specifically helpful in autoimmune sclerosing cholangitis if there are biliary dilatation which can be seen on ultrasonography. How do you get biliary dilatation in sclerosing cholangitis? The mechanism is due to the inflammation of the ducts, you get stricturing. However, on ultrasound scan, you can't really see stricturing because they are small areas. Due to these strictures, you will see proximal dilatation, which would indicate the distal stricturing. So what radiologist would look into is these dilatations, which would indirectly indicate that there are strictures in the distal part. So we would write in the request form that we want to see the biliary dilatation. And other routine information may be useful, the liver echogenicity, focal lesions, in the context of chronic liver disease, spleen size, in view of portal hypertension, ascites, intra-abdominal varices, portal vein patency, in view of transplant if we are planning for the future, and sometimes large gallbladder is seen again in association with sclerosing cholangitis. The next modality of imaging is MRCP. So MRCP is very important and it's very useful. The problem is it's not sometimes freely available. Child needs to go through anesthesia. So those are the challenges we have. But in developed countries, they do couple MRCP with all the cases suspected to have sclerosing cholangitis. So this is a classical feature. You can see beading. The arrows nicely show the areas of beading with the dilated areas, and you can see a stricture in the middle. What is the place for ERCP in children? ERCP is a very good investigation as well as a therapeutic modality. It's endoscopic retrograde cholangiopancreatography. However, the problem or the challenge in children is the technicality, because the scopes are not that small where a child can be intubated and cannulated in view of the bile duct. So it's quite difficult to cannulate the bile duct in a child due to anatomical reasons and the size related problems. So its use is quite limited unless we use it in an older child to manage strictures, to put stents and all. Diagnostically very, very limited due to these practical difficulties. What are the other investigations which might be helpful in this context? If we have a child who is diagnosed to have autoimmune liver disease, it's always good to look for other associated autoimmune liver diseases. However, we have to follow a cost-effective approach where we can't be screening for all the things. Maybe we can do the common things as well as the clinically relevant things. Exclusion of other associations of autoimmune liver disease like autoimmune hemolytic anemia is important. And obviously we have to exclude the competing differential diagnosis. And if there are clinical features or if the biochemistry is suggestive, we have to look for the presence of IBD by the use of colonoscopy. So having discussed about the clinical features, investigation, so now we have a child we have diagnosed with autoimmune liver disease. How would we treat this child? Coming back to our types, we have three main types, and under autoimmune hepatitis we have two main types, and we have overlap syndrome as well. So how do we treat? Mostly it is immunosuppression with or without ursodeoxycholic acid, and supportive care and limited use of ERCP. Failing all these measures, the ultimate cure, if it is required, would be liver transplantation. We will come to individual therapeutic strategies in next few slides. Before that, with those therapeutic modalities, what are we trying to achieve? What are our therapeutic goals? So if we have a child who's diagnosed with autoimmune liver disease, we want that child to be free of symptoms. So no symptoms. If the jaundice is there, it should disappear. Biochemical remission. Normal liver biochemistry, normal AST/ALT. So in children, as I mentioned earlier, we are very aggressive in treating autoimmune liver disease. We do not accommodate even slightly raised AST/ALT. In comparison, adults, they do accommodate up to twice the time of the normal transaminases. Possibly due to the increased lifespan and many more years ahead in their lifetime, we would treat autoimmune liver disease very aggressively in children. So we really need normal AST/ALT, normal immunoglobulin levels and negative autoantibodies. That is what we want to achieve biochemically. And we are not going to stop there. We really need histological remission, because you can have a child who is in clinical remission, biochemical remission, however not in histological remission. So that means the damage continues. The damage continues and it will cause fibrosis and ultimately will require liver transplantation, or the child would die in the absence of transplantation. So we really need to have histological remission and we need normal liver histology. So those are the main therapeutic goals we should have in mind when we manage a child with autoimmune liver disease. However, these goals should be achieved with minimal drug-related adverse effects. So we can't be using steroids for a long time, very high doses unnecessarily. We should try and minimize the doses we use with other immunosuppressions to minimize the adverse effects. Because again, the children will have 50 years, 60 years ahead in their life where they might sustain these drug-related adverse effects compared to adults, like secondary malignancies and other diseases. So it's very important to use these drugs with these things in our mind to achieve therapeutic goals mentioned here. Now we shall look at individual drugs and how they are being used. So the mainstay of treatment, medical treatment, is steroids. Prednisolone, the starting dose is 2 milligrams per kg per day, and to be tapered off within 6 to 8 weeks. Once a second line agent is introduced, most of the time we will need a second line drug. And no point starting with 1 milligrams per kg or a lower dose. You have to start with a higher dose and get the disease control early and then taper off. Sometimes you might not be able to stop steroids at all if there were previous relapses or type 2 autoimmune hepatitis or severe disease. You might have to continue steroids in low dose. Sometimes certain units use prednisolone every other day therapy in research that has shown the every other day therapy is less effective. Instead of that, you may use a small dose daily basis. And when you are using high dose steroids, it's very important to couple it with a proton pump inhibitor in view of gastroprotection. Sometimes they may have chronic liver disease and they may have portal hypertensive gastropathy and they might bleed. So it's very important to give gastroprotection and monitor for adverse effects of steroids, which I'm not going into details, and we all are aware about the drug-related side effects of steroid. The next drug, and the drug which is mainly used in view of maintenance, is azathioprine. It is steroid sparing. That is the main reason we need to add azathioprine, because we can't be using high dose steroids for a longer time due to its side effects. So we really need something to come in to maintain the maintenance, which is azathioprine. The timing of introduction of azathioprine, is it at the beginning or maybe after some time? The best time is once you have achieved near normal transaminases or normal transaminases. There is a reason for that. If we have a child with autoimmune hepatitis, we do not start prednisolone and azathioprine both together. The reason is azathioprine itself can cause a hepatitis kind of a picture. So your clinical picture will get complicated. You do not know whether the drug is causing this or whether the original disease is causing this problem. So the best way is to induce remission with steroids, and towards near normal transaminases, you add azathioprine to maintain remission. In developed countries, as a routine, they do TPMT, which is an enzyme which involves with metabolism of azathioprine prior to commencement of azathioprine. Unfortunately, we do not have that facility. This is to avoid toxicity as well as to see whether the drug is being metabolized. So this enzyme is needed. Some people do have deficiency of this enzyme. So actually we are treating kind of a blind scenario where we do not have really drug levels or metabolite levels or enzyme levels to be monitored. But in ideal setup, this is what the people would do. Following commencement of azathioprine, again you can monitor its metabolites. One thing to indicate whether the patient is taking the medication, which is by 6-TGN. If you do a 6-TGN on a child who is on azathioprine, if it is low, you know the child is not taking the medication, or else you might have to increase the dose if the compliance is very, very good. On the other hand, it might indicate the toxicity as well. The starting dose of azathioprine is 0.5 milligrams per kg per day, and the maximum is 2 milligrams per kg per day. The common side effects we see are cytopenia and hepatitis. Though hepatitis is listed as a side effect, and though we do take precautions, it's relatively uncommon to occur. But we do take precautions by adding it quite later on. The other immunosuppressive drugs are MMF, mycophenolate mofetil, tacrolimus or sirolimus, and cyclosporine. Nowadays, tacrolimus is becoming more popular instead of mycophenolate mofetil due to its side effect profile, because MMF causes a significant diarrhea in certain individuals and cytopenia. Compared to that, tacrolimus is relatively safe. And we can monitor the drug levels as well with tacrolimus, so it's quite easy to use. These are supportive medications. Ursodeoxycholic acid is beneficial in cholestasis associated with autoimmune hepatitis as well as autoimmune sclerosing cholangitis. The dose can be used up to 30 milligrams per kg per day. Fat-soluble vitamins, not routinely needed in everybody. If there is associated cholestasis or proven fat-soluble vitamin deficiencies, you may use. And controlling bowel disease with the respective medications is also very, very important, especially in autoimmune sclerosing cholangitis. The medications used to control IBD are the standard medications like mesalazine, steroids, and anti-TNF alpha. Oral vancomycin has been described in treatment of IBD-associated autoimmune sclerosing cholangitis. And there is literature which has shown that this is effective. If you do not have any other way to escalate your treatment, you may use oral vancomycin to control the liver disease associated with inflammatory bowel disease. Having heard about those standard therapies, the novel therapies are also being explored. There are studies going on about the regulatory T cells, because the T cells play a role in the pathophysiology. So nowadays they are studying whether they can regulate the process so they can control the autoimmunity through T cells as well as mucosa associated invariant T cells, which are called made cells. Let's summarize our treatment pathways. So this is a nice chart actually, which makes our lives easier. So if you have a straightforward diagnosis, if you have a child with elevated transaminases, immunoglobulin, as well as positive autoantibodies with compatible histology, in ideal setup, you would do MRCP and then differentiate between autoimmune hepatitis and autoimmune sclerosing cholangitis. This guideline is made for the developed countries and for the West. So if it is autoimmune hepatitis, cholangiogram negative, you would start prednisolone and azathioprine. Autoimmune sclerosing cholangitis, again, you will couple that with ursodeoxycholic acid. Everything goes smoothly, you achieve remission, you give 3 years of treatment, normal transaminases, normal immunoglobulin, normal histology after 3 years, you attempt withdrawing, provided it is not autoimmune hepatitis type 2, where you would need lifelong treatment. If the life is not that easier, if you do not get a response, though the diagnosis is autoimmune hepatitis, you have other medications like cyclosporine and cytotoxic drugs, or ultimately you might go ahead with liver transplant. Again, similar scenario for autoimmune sclerosing cholangitis. If you do not have a response, you have other medications as illustrated here, and ultimately you might have to go for liver transplant. So this is kind of an escalation pathway if we have a child with autoimmune liver disease. So now we have diagnosed and we have treated, and how should we follow up? What are the things we should be monitoring? So during the follow-up, we should monitor the disease activity in view of clinically, biochemically, and histologically. So clinically, obviously, we would ask history, symptoms, signs. Biochemically, we would do liver enzymes, liver profile. We need to do immunoglobulins for the follow-up. We need to do autoantibodies for the follow-up infrequently, but we need to do. Liver biopsy is needed if the disease is not responding. Again, you have to look for other etiologies and the response to therapy, you might need to do a liver biopsy. Or else if you are prepared to stop immunosuppression as the child has responded very well, again you will need a liver biopsy. Good way or bad way, you might need a liver biopsy in the end, but not very frequently due to its invasive nature. We should remember to monitor for drug side effects and monitor for other aspects of chronic liver disease like surveillance endoscopies for portal hypertension, optimization of nutrition, and all these things. We should look into immunization, especially in the context of immunosuppression, and the drug doses and omitting drugs during an infection, especially like varicella. You might have to withhold the drugs for a short period to avoid dissemination of infections. And it's very important to identify and treat relapses quite early because otherwise the liver damage would progress. And if you have raised transaminases in a child who was under control previously, before thinking of relapse, always think about poor adherence to treatment. Because it may be that child has stopped treatment and now getting a relapse due to that. So you have to make sure they get the treatment before you escalate the drug doses. And one important point which is very crucial to explore the other etiologies even after the diagnosis is made for many years. You might have a child whose diagnosis was made many years, but you don't have a child who is responding. The transaminases are still high. So then again go back and evaluate for other diseases because autoimmune liver disease may not be the diagnosis if you haven't achieved full remission at any point. When and how to stop therapy when you are on treatment, autoimmune hepatitis type 2, lifelong therapy because otherwise they'll relapse. Autoimmune hepatitis type 1, if the child is in remission for 3 years and if you have proved histological remission, you can consider stopping immunosuppression but under close surveillance. The timing of the liver biopsy, they say at least you have to keep minimum of 6 months from the normalization of biochemistry for you to do a liver biopsy. Because otherwise you might not see histological remission. It's a waste of time and waste of time as well as a risk to the child that you do a liver biopsy quite early. So if you get normalization of biochemistry, wait for 6 months and then do the biopsy where there is high chance you would pick up a remission. And obviously if there were previous relapses, you might consider longer duration of therapy. Autoimmune sclerosing cholangitis, again possibly lifelong or till liver transplant. De novo autoimmune hepatitis, same as for other types, depending on its type. Moving into liver transplantation for autoimmune liver disease, the ultimate cure for the children who has acute liver failure, not responding to medical therapy, or children who have got cirrhosis, established cirrhosis as a result of autoimmune liver disease. This is the ultimate cure. Indication actually same for the other liver diseases. When we list a child for liver transplant, we look at their synthetic functions, we look at their degree of portal hypertension and etc. So indications are same as for other liver diseases. However, there is a recurrence risk in transplanted liver compared to other disorders. And the recurrent risk is quite higher in autoimmune sclerosing cholangitis, which could be up to 30%. So, liver transplantation for autoimmune liver disease, the ultimate cure for a child who's coming with acute liver failure and not responding to medical therapy. as well as for a child who has got established cirrhosis, again would not respond to medical therapy because there is established cirrhosis. So the indications for the liver transplant in this disease also are similar for other liver diseases, like decline in synthetic functions, the degree of portal hypertension. All these things would come into play when we decide on the liver transplantation and the timing. The interesting feature is the recurrence of the disease is possible in autoimmune liver disease compared to other disorders. The recurrence rate is quite higher in autoimmune sclerosing cholangitis compared to autoimmune hepatitis. The recurrence rate may be up to 30%. So there are a few things that we could do to minimize this risk of recurrence. One of the main things is controlling the inflammatory bowel disease in IBD associated liver disease. Because if you transplant a child who has got IBD and IBD associated liver disease, without getting good control of the bowel, there is a higher chance of recurrence of the disease in the transplanted liver. So the clinician may decide to go ahead with colectomy if it is ulcerative colitis before transplant to gain the maximum benefit of the liver transplant. Having said about the recurrence, autoimmune liver disease is not a contraindication for liver transplantation. It is very well indicated and children do well, though the minor percentage would recur. So it's indicated, it's not an contraindication. We should not step back at any point thinking that it's contraindicated. And there is one important thing in regards to the immunosuppression protocol. In children following a transplant, we do not normally consider giving steroids. Certain units, they do use steroids in the transplant protocol, but mostly the people will not use because of the side effects and the longer duration of therapy. However, this is one indication where we can't give immunosuppression without steroids because there's high chance of recurrence. So if you have a child with autoimmune liver disease, mostly your post-transplant protocol will have steroids. You can't get away with it. Lastly, but importantly, in view of liver transplantation, counseling and donor assessment is very, very important. What do I mean by it? If you see a child with autoimmune hepatitis at the first presentation, and child has got significant transaminitis, and the biopsy says some degree of fibrosis. So as the starting point, you would get the disease under control and you would do all the other things. But one important thing we should be doing, especially if the fibrosis is quite significant at first presentation, that is counseling of the family in view of liver transplantation and the preparation of potential donors. Because we know if there is significant fibrosis, this child will ultimately require liver transplantation, or there is a high chance of this child requiring liver transplantation in 2 to 3 years' time. So there is no point we looking for a donor in the context where we do not have cadaveric donors. We are really dependent on live donors, mother or father. No point looking for donors in a rush when the child has got end-stage liver disease. Knowing this child will require liver transplantation at some point, we should check the blood groups of the parents as well as advise them thoroughly to lose weight as well as to manage their comorbidities and to avoid getting diabetes for them to be potential donors for their child. That is a very important thing I would like to highlight because we see a lot of challenges when it comes to transplant in end-stage liver disease because we do not have good live donors. Parents have got, almost all the parents have got fatty liver and some of them have got diabetes. So it's really important to stress on this fact, and anyway this would be beneficial for them despite the child requiring liver transplant or not. So that is very important and I would really like to highlight that fact. Right, moving into de novo autoimmune hepatitis in the transplanted liver. The definition is occurrence of autoimmune hepatitis, autoimmune liver disease in the transplanted liver when the primary disease was not autoimmune liver disease. If the primary disease was autoimmune liver disease, we would say recurrence of the same disease. We would not call it de novo autoimmune hepatitis. It's a different entity compared to recurrence in an autoimmune liver disease child. The same principles of diagnosis and medications would apply, the same diagnostic test and same treatment modalities we have to use as for autoimmune liver disease. Forgetting this child had a transplant for a while. And this clinical picture, this problem is not really responsive to standard anti-rejection medication, though they are also immunosuppressants. Those medications as well as those doses we maintain would not be helpful. So we really need to diagnose this. If you have a transplanted child, raised transaminases, firstly exclude rejection. Secondly, you can think about this as well. This is a very important diagnostic entity, seronegative autoimmune hepatitis. I was talking about autoantibody positivity in relation to autoimmune hepatitis. However, there can be autoimmune hepatitis in the absence of circulating autoantibodies, which is called seronegative autoimmune hepatitis. All the other features are present up to a greater degree. You will see the typical biopsy, but you will not have circulating autoantibodies. And yes, we have to exclude other etiologies before we diagnose this condition. And the treatment is similar and they are responsive to immunosuppression. And considerable percentage may be associated with aplastic anemia. That is again interesting. If you have a child with undiagnosed hepatitis, kind of a picture with aplastic anemia, this may be the diagnosis. There was a nice study where they have evaluated 38 children with seronegative autoimmune hepatitis, and they have described 10 out of 38 had aplastic anemia. And all of them responded to immunosuppression just like for other autoimmune liver diseases. What about the prognosis of autoimmune liver disease? So few facts to highlight the prognosis. It would depend on the disease status, the fibrosis at presentation, and the nature of presentation, and all the factors. In addition to that, the type 1 autoimmune hepatitis might have significant fibrosis at first presentation compared to type 2. Though type 2 requires lifelong immunosuppression, the type 1 might result in significant fibrosis. Sclerosing cholangitis is less responsive to immunosuppression. We have to anticipate that. And early and adequate treatment actually will result in good prognosis. It might prevent requiring liver transplantation. Ultimately, if we happen to do a liver transplantation, overall it is very successful and the prognosis is good. So that brings me to actually the end of the presentation, and now I have got 4 case summaries to apply what we have gone through today. So we will see what are those case summaries and what were the challenges the clinicians face in day-to-day life. So this is the case summary 1. A 12-year-old girl diagnosed to have autoimmune hepatitis since 4 years of age based on histology. Immunoglobulins normal, ANA positive, other antibodies negative. An evaluation was done for Wilson's disease and other etiologies, they were negative. So what are the possibilities? What are your thoughts? The child received high-dose steroids intermittently together with azathioprine and MMF alternatively. However, the child did not achieve remission or the full disease control. Child was sent to ophthalmologist at the age of 11 years. The initial diagnosis was made at 4 years and child was sent to ophthalmologist at the age of 11 years in view of looking for side effects of steroids. Ophthalmologist had made a note about cave rings, which was not actually asked. Then the child was re-evaluated. On re-evaluation, child fulfilled Wilson's diagnostic score of 4 and commenced on treatment actually at that point. And the genetics confirmed the diagnosis of Wilson's disease. Later on, 2 mutations were present. And child improved with chelation. For the first time, child's transaminases normalized. So this case history highlights the importance of looking for other etiologies, especially when you do not have the full disease control in vivo of autoimmune hepatitis. So if you critically look back, this child was diagnosed based on the histology in a context where immunoglobulins were normal, though ANA was positive. However, the evaluation for other diseases were negative at that point. But the key feature was child did not have full control of the disease. So that would have actually led to exploration of other diseases. Somehow it came into the picture. So the main message is if poor response to treatment, re-evaluation of the disease maybe after many years would give you a good yield. Case summary 2. A 2-year-old boy presented with acute onset jaundice and dark urine for 2 days. No other symptoms. Examination normal apart from jaundice. The transaminases were hovering around thousands. As the commonest differential diagnosis suspected of infectious hepatitis because of acute presentation, otherwise well child. All investigations were normal. Is this a self-limiting infectious hepatitis where we do not really see the virus? Child was kept on follow-up. Transaminases settled down to hundreds within 2 weeks. Quite marked improvement without any specific treatment. Assumed a self-limiting acute hepatitis. 2 months later, child remains asymptomatic. On follow-up review, the bloods revealed transaminases are rising back to 500, 600. And all the investigations were repeated at that point, where it revealed raised IgG and positivity for ANA and anti-smooth muscle antibodies. Subsequently, liver biopsy confirmed autoimmune hepatitis. So this case history highlights the initial settling down of transaminitis without any specific treatment or immunosuppression would not exclude autoimmune hepatitis. It can fluctuate, but still consider the possibility of autoimmune hepatitis if the transaminases are not fully settling. That is the main message. Case summary 3. A 7-year-old girl presenting with a clinical picture of acute liver failure. On evaluation, actually the clinical picture indicated acute on chronic liver failure rather than just acute liver failure because there were features for chronicity. She spontaneously came out from the acute episode with supportive care. However, the primary etiology remains unclear. There was a dilemma about the Wilson's disease as well as autoimmune hepatitis. Immunoglobulins were raised towards autoimmune hepatitis. Liver biopsy showed chronic active hepatitis. And they have given the possibility of both autoimmune hepatitis and Wilson's disease. Cave rings were positive. Cereudoplasmin mildly low. And ANA positive. Where do we stand now? With these dilemmas and repeated discussions, the child was diagnosed as Wilson's disease based on the Wilson's diagnostic score and commenced on chelation and improved before the genetic results available, and later on the genetics confirmed the diagnosis of Wilson's disease. What does this case teach us? Polygammaglobulinemia or raised immunoglobulins may be present in any chronic liver disease. And here ANA positivity could be there in normal population. However, presence of cave rings is quite significant. And you can always put Wilson's diagnostic score when you have a doubt pending genetics. Last case summary. A 10-year-old boy is found to have incidentally raised transaminases which were in hundreds while being investigated for a viral illness. Follow-up bloods. Persistent transaminitis. Child is obese and ultrasound scan showed fatty liver. Child was very good and was able to reduce weight by 2 kilograms. Transaminases got better to 50s. Everything is moving in the right direction. Follow-up bloods in 1 month. Again rise in transaminases. ANA positive. IgG normal, ceruloplasmin normal, and no cave rings on ophthalmological review. What should we do next? Yes, the liver biopsy was planned and performed because we have to look for the possibility of autoimmune liver disease, though it could not be, because we can't miss autoimmune hepatitis. So the liver biopsy was performed. It revealed NASH, non-alcoholic steatohepatitis, and there is no evidence of autoimmune hepatitis. That is good. We have not missed a diagnosis of autoimmune hepatitis for the time being at least, and we will manage that child as non-alcoholic steatohepatitis. The lesson through this is, though the biopsy could be negative, always good to look for autoimmune hepatitis. No harm, because rather than missing autoimmune hepatitis, that's okay to look through. And rapid weight loss in this case can cause rebound transaminitis, possibly that is the reason. That brings me to the end of the presentation. So I would like to sum up. Autoimmune liver disease is a common treatable liver disease in childhood. The diagnosis is often delayed and mistaken due to lack of single objective test. Constant surveillance into the possibility of autoimmune hepatitis and vice versa is important. Adequate treatment with meticulous monitoring will prevent development of cirrhosis. And if happen to do a liver transplant, the overall prognosis is good. These are the references. And thank you for your patient listening.